Just a little bit about myself first, because we've been talking to people that do kind of outpatient care. I practice primarily critical care, and you might ask yourself, well, how did a critical care physician get into lifestyle medicine and plant-based nutrition? And the reason is easy, and it's the reason that, basically every single bed in the ICU is occupied by a patient that has the end stages of lifestyle-related disease. On a random day in ICU this past September, I just took a little survey. 50% of the patients were patients with the acute end stages of some lifestyle-related disease like COPD, hepatic encephalopathy from alcohol, cardiogenic shock because they've had an MI. So some of them there are acutely because of their lifestyle. The remainder are there with something that we would have classified as bad luck. Oh, I got a pneumonia and I'm septic. But it's not bad luck. When you look at those patients, they have an average of 8 lifestyle-related comorbidities and an average of 11 medications. The average BMI in our ICU on a given day is about 30. So it's not bad luck that you ended up in the ICU. It's poor lifestyle choices, and that's for almost every single bed. Even the overdoses could be classified as lifestyle-related disease. And sadly, we're seeing an opioid epidemic, and it's very, very bad. Before I sort of introduce our panel, I just wanted to introduce some of the topics that we want to cover here and some of the resources. So first of all, a show of hands, because we have people from various backgrounds here. First of all, how many MDs do we have in the room? Just a show of hands. Excellent, excellent. How many other healthcare providers? Okay, so majority of the room, and just lay people that are interested or in the healthcare related fields. Okay, lovely. So kind of in thirds there. So that's wonderful. So basically, for those of you that are healthcare providers, I'm going to ask our panel to speak a little bit about what resources they used and how they got themselves educated in lifestyle medicine. And a few things we're going to talk about are courses that we've taken, where you can go to get these courses. And the other thing is certification, so U.S. board certification in lifestyle medicine. Sadly, lifestyle medicine is not a recognized specialty in Canada. So the only surrogate that we have right now is to be U.S. board certified. And several of the panel members here are, and we'll talk briefly about that process as well. And the various courses that you can take, some of which have been mentioned. The other thing that I want to mention is that a lot of us are joined together through social media because right now, as Larry alluded to, we're trying to get organized to revitalize the Canadian Academy of Lifestyle Medicine, soon to be named the Canadian Association of Lifestyle Medicine. So if you're interested in being connected when that is up and running, there's a sign-up sheet at the registration desk. And I encourage you all to put your email addresses down there, and that way, once our website is up, we can all connect through that, and we can recruit membership. And what the things we want to do there are we want to have resources for healthcare providers and patients, a healthcare provider directory, so patients know where to go to get this help. And also advocacy. Like recently, Health Canada was working on new guidelines, and we didn't have an organization, well, we had an organization, but we weren't organized yet to really push into giving input to Health Canada. We did so as individuals and as little groups, but we need to get super organized and be recognized as an association that can drive change, and so that's really super important. Anyway, without further ado, I want to turn to the panel to talk a little bit about how they went about increasing their expertise. And I'm going to start with the people that have U.S. board certification and talk a little bit about that process. So Jen, I know you, oh, sorry, I'm just going to randomly pick people here.
Okay, sure.
Jen, you recently became...
I did board certification in lifestyle medicine. The first year it was offered, which was 2017. For everybody in the room, if you haven't looked at, there's different courses out there, but this is for everybody, whether they're in the healthcare field, whether they're a physician or not. The Cornell, it's an online certificate, Cornell certificate in plant-based nutrition. That is the thing that gave me the confidence as a doc to start talking to my patients, because I had started talking to patients before if they had chronic pain, for example, but I wasn't convincing because I didn't have the confidence, and I really felt there was a real shift. Once I had that certificate under my belt, it's an excellent course, although I should add that they've revamped it since I took it, because I think I took it in 2015 or early 2016. The other thing too is Dr. Podolesky, he still does about 1 day a month at the Cleveland Clinic. It's a 1-day seminar for patients and their spouses, because as we were hearing today too, if you don't have, like if you can get the spouse to come out to educational sessions or whatever, or just to come into your office, good luck. And whatever you talk about, they may not be able to succeed because they don't have the spouse on board. And keep in mind, he's usually seen patients who are very sick with cardiovascular disease. He will invite clinicians to attend for free. All I had to do was get myself to Cleveland, Ohio, so I drove, and find a place to stay, and I and other clinicians were in the back of the room while he spoke to patients and their partners, and then his wife talked about, she taught them all how to be a good stripper, and by that, how to strip kale. So, and that was completely free. So, for me, that was my experience.
Can you repeat that?
I'm sorry.
Can you just repeat the second part?
Oh, Dr. Podolesky?
Okay.
Yeah, if you go to dresselstein.com, and if you go to the bottom of the website, there's actually an email address, and where you can email questions, although you're asked to limit any questions about cardiovascular disease. But he, at conferences, he has invited medical doctors to come and attend his clinic and just observe for free. In my case, I happened to email a question, and then after the second time he called me back to answer my question about heart failure, because at the time there was nothing reported about heart failure benefits from whole food plant-based. And he said, talk to my secretary if you'd like to come down for a day, which was lovely. So.
Yes. So his basically he gives out his secretary's email at conferences, and you contact her. But I do have that email address. I don't have it memorized. I'm plantbasedmd.com, and there's a little contact button. Contact me, and I'll get you in contact with Russell's secretary.
Yeah, and I would echo some of the same comments. I went to the Institute of Lifestyle Medicine conferences at Harvard 2 years in a row, and then went to the American College of Lifestyle Medicine 5 years in a row. And when you go to those conferences, I think you finally realize you've found your tribe. It's the only conference I've ever been at, especially the first 2 years, where you ate plant-based for 3 days in a row. And the food, the recipes are all posted online once you hand in your evaluation. And so you can go home and make all of these wonderful meals. It's completely certified. They actually send a team to the conference centers much in advance to make sure that everything is done to their standards. And then when we all took the exam, there's a board review course, which is a 200-page booklet. There's also, as part of the board review course, there are also some webinars that you do in person with the two people that wrote the board review course. You could argue whether it was good or bad. It was probably extra, a lot of money for not that much more information. But I took the certification exam at the age of 65, and it was probably one of the hardest things I've ever done in my life. Because it was a 3-hour multiple choice exam.
4 hours.
Or 4 hours, yeah. Well, some of us are done in 3 hours. No, I'm just kidding. But about 50% of the exam was on nutrition, and as a physician, that was daunting to know. All these studies you heard about today, where there were multiple choice questions on all of those studies. There were studies on behavior change and tobacco and exercise and a whole bunch of different things. So it was a daunting exam, but I'm glad I did it. It was, I felt I wouldn't have the credibility if I didn't do the exam. And in fact, Michael Greger was sitting next to me, the guy that wrote the book, How Not to Die. He took the exam, even though he wrote most of the questions. But they all felt because it was the inaugural exam that we should all be diplomats and certified to do it.
Exactly.
And then since then, Beth Frades from Harvard has published a wonderful, and I would ask all the family docs out there, if you want to get the first really good textbook on lifestyle medicine, it's by Beth Frades, F-R-A-T-E-S. You can get it off Amazon. But the neat thing about Beth's book is she has actually highlighted a lot of her a lot of the evidence using illustrative stories with patients. So it's very much narrative medicine embedded in a book that has all the evidence. It's very well referenced. There's all the papers that you heard today talked about are referenced in her textbook as well. So it's a great, in fact, our special interest group at Western, most of the students have ordered it because we got a good deal from the publisher on it. So.
Okay. So if you want to know where to go to get board certified, it's called the American Board of Lifestyle Medicine, and there they list the prerequisites and everything you need to do. So you need to take a variety of courses, most of which are online. You need to do some attendance in-person conferences. I don't know if they've removed the case report, but there was a case report that you would have to submit. But essentially there's a couple of other courses that I really want to point out, and one of them is the American College of Preventative Medicine. So the American College of Lifestyle Medicine is sort of a subsidiary of the American College of Preventative Medicine, and they have a core competencies course in lifestyle medicine that has a nice section on nutrition, and Dr. Greger is one of the profs for that. But anyway, essentially the exam is based on the core competencies course. If you've taken the core competencies course and know that content well, you can pretty much pass the exam. The other courses were already talked about here. So again, American Board of Lifestyle Medicine, and you can see all the prerequisites there. And they offer a board review course. So the American College of Lifestyle Medicine offers a board review course, so you can sort of go through everything and have a little bit of confidence going into the exam. So that's a part of what we were going to talk about. Another just quick plug for how do we get connected on social media until we have our Canadian Association of Lifestyle Medicine. We do have a Canadian Plant-Based Nutrition Healthcare Forum. That's Canadian Plant-Based Nutrition Healthcare Forum on Facebook. And all of us here, that's how we sort of met, except, other than meeting all the time at conferences. So that's one resource. And another resource are the conferences themselves. So this is the first annual Canadian one, and we should all be coming to this and advertising amongst our colleagues. But there's also the Plant-Based Nutrition, International Plant-Based Nutrition Conference that's held annually in California, and the next one is in Orlando in September. And also the American College of Lifestyle Medicine that was already mentioned. And those are key conferences. And Harvard always has a conference in May that is also very good through the Institute of Lifestyle Medicine, I believe. Anyway, the other thing I want to discuss, and we'll get the people that are university affiliated, to talk a little bit about getting lifestyle into the curricula and lifestyle medicine interest groups. So right now, lifestyle is not officially integrated into the curricula at most schools, believe it or not. And yet, in the next couple of years, the LMCC, which is the exam that the students have to write in the end to qualify for being a doctor, is that 20% is going to be lifestyle related. So it's going to have to be integrated into the curriculum. But in the meantime, we're starting to see lifestyle medicine interest groups crop up. And the students themselves are trying to get this going. So there's money at medical schools. If you're affiliated with an academic center, it might be good to help encourage the students to develop an interest group. And Larry, I know there's one at Western. How's that going? Sorry.
Yeah, no, the Western one, we actually had our first symposium, and they have an interest group for nutrition, yoga, exercises medicine, which is a campus thing that I think all the campuses in Ontario, maybe in Canada have. But the lifestyle medicine interest groups in American universities is really growing. There's about 40 of them in the medical school system down in the States, so they're growing very quickly. I think North Carolina is actually starting a PGY 3-year in lifestyle medicine, so it's becoming, as we've heard, a rapidly growing subspecialty of family medicine. Because in the States, so many of the big HMOs do something we call value-based care, and what they found with them and some of the large corporations is that the return on investment, if you do a lifestyle medicine program, is 6 to 1. So for every dollar you put in, you get 6 saved. And so it doesn't take a brilliant doctor or a brilliant business person to figure out that's a pretty good deal. And so I think that's why it's rapidly growing. I know when my wife took the Life Coaches program through Harvard, She was in a study group of 20 other women, and they were all from Boeing in Seattle. And so a lot of these big corporations are hiring lifestyle coaches that are mostly social workers and nurses to do a lot of their lifestyle coaching, because they save tremendous money on insurance premiums and drug costs when people start to get healthy. Yeah. The other plug I want to put in too is the American Board of Lifestyle Medicine is actually, it's not just a physician certification stream anymore. There's a nurse practitioner stream, there's a dietitian stream, and so the other streams are coming. I mean, I think at some point there'll probably be a naturopath stream and a chiropractor stream and those sorts of things, because we know that there's lots of us out there that do very, very similar work, and as long as we subscribe to the same philosophy of care, then it's not a one-size-fits-all.
I believe PhDs and masters in related fields can also sit the exam. So Subhas, any comments on what we've said so far?
Yeah, two quick things, I guess. Okay, so one is, the one thing we haven't mentioned is PCRM.org, the Physicians Committee for Responsive Medicine. They have a conference in July, which is pretty intense, but it's a couple of days long. They also have a kind of like a mini textbook of lifestyle medicine, and it basically lists all of the diseases in lifestyle medicine, angles on that. I'm involved in the nutrition interest group as well. I run something called GI electives, where medical students can get experience in GI. And because of that, I was able to flip. I have a food as medicine elective now at McMaster. So if you know any medical students, they can go through the usual channels to check out electives, and they can actually do a food as medicine elective at McMaster. One last thing I just wanted to throw in, because I always like the idea of driving change and getting physicians involved in this, and it's funny, they're either interested or totally disinterested, but I think there's a simple way we might be able to drive change, and it's basically gonna cost about $20. And basically, it's real simple. If you're a patient, and most of us are at one level, you buy either a copy of Forks Over Knives, the DVD, or a book, the book How Not to Die. You look your doctor in the eye and you say, I've looked through this, I'd really like you to look this over and tell me what you think. And next time I see you, I'm gonna ask you. And the first one, they'll probably just put aside and do nothing, but I would think that once a doctor gets 2 or 3 copies of DVDs, Forks Over Knives, piling up in their office, and 2 or 3 copies of the book, How Not to Die, sooner or later, either they'll look at the back of How Not to Die and notice there are 2,000 references to the peer-reviewed medical literature, but it's a simple thing, but I think at a patient level, I think it would actually drive change. Not the first one, but the second or the third.
And I'm just going to mention the PCRM textbook is an app. It's a free app, and so you can do that. And that's Dr. Barnard's group, but the app is superb and an excellent resource for students if you want to refer that to students. I should mention Queen's also has a lifestyle medicine interest group, and I think those are the only 2 right now in Canada. Okay, and yes.
Actually, the other thing somebody's got a computer open, you might even look this up if you're connected to the internet, but Erica Frank from UBC has been involved in a huge project called Nextgen You. Nextgen You is an online lifestyle medicine education program that's free. And I haven't looked it up yet, but I've heard that it's been launched. They had a multi-million-dollar seed grant given to them to run this, and I think they've been doing it with the Israeli Lifestyle Medicine Association. I mean, the neat thing is about all these global lifestyle medicine associations is they're all willing to share curriculum without cost. So nobody needs to reinvent the wheel. It's the same problem no matter what country you're coming from. But yeah, I think Nextgen You might be the next edition, you know, and it looks like it's a large repository of information.
Okay, and Dr. Raypudi.
A few things that really helped us was observing others who are already doing it. Now, there are people who are doing it, and you don't have to reinvent the wheel. There are systems that are working. And for us, observing Dr. Shane Williams and learning from Dr. Esselstein, Dr. McDougall, doing it in a group setting is very, very powerful compared to doing one-on-one. Other thing is, most of the time, the physicians and healthcare providers, we are stuck in our head. Like we are left-brain people, like we are thinking in terms of numbers and logic, but you need to connect with the patient. So, like for the information transfer to happen, the connection has to happen. Unless we can get the patient, we have to use their whole brain, the right brain, the left brain is the logical brain and the right brain is the emotional brain, unless we have systems where they're inspired, they're motivated, and they also feel supported. The information alone will not change. Like, when we started learning about this, we thought, like, if you just told, we were so excited to learn about this, plant-based nutrition, just do this and you can reverse your heart disease. But you have to hold their hand, you have to, give them the tools to support it. So whichever practice, whichever model you go with, if you don't have these components to address emotional eating, some of us who have been doing this for the last 4 to 5 years, we learn it's not only what you eat, it's also important that we focus on how we eat and why we eat. So once we establish those aspects, because even the plant-based eaters, there are, I would say 30-35% of the plant-based eaters are emotional eaters. We are seeing a lot of people who switch to plant-based eating still struggling to lose weight. So we have to address those aspects as well.
Wonderful. So okay. Just quickly on that note, what I've been able to find in my library, and yes, and at the Ottawa Public Library, but if you check out your library, there's a lot of books out there about mindful eating, and so that can help, because I may or may not be an emotional eater as well, even though I'm whole food plant-based with some oil, which isn't a whole food. But looking at mindful eating could be helpful, whether we're doctors, whether we're patients, or whether we're doctors who are not as healthy as we could be. So, thank you.
And those who are interested in the research and actually reading some of the primary literature yourself, there are a variety of places that you can go. The PlantTrition Project, which runs the International Plant-Based Nutrition Conference, have a link to a site called plantbasedresearch.com that was started by a PhD student that worked with T. Colin Campbell. Her name is Michaela Carlson, and it's a searchable database. So that's one place, and you can go to the PlantTrition Project to look that up. The other thing is we have a Canadian, Dr. Tushar Nahad, who is here today and a classmate of mine. There he is. And he's going to be speaking later, but he has a link to a Dropbox and to a list that he's been keeping since a long time ago of all the literature related to plant-based nutrition and also some of the environmental aspects that he's going to talk about in his talk. If you go to our social media, the Canadian Plant-Based Nutrition Healthcare Forum Facebook page, we will post the links to Tushar's list of research. It's extremely comprehensive, and I encourage you to have a look at that. I think unless there's other comments from the panel, I'd like to open it up to questions. So we have some time for questions. So if somebody, do you need this? Can I use this one?
Hello. Hi, I'm up here. I got a bunch of stuff on my lap. Hi. Sego, my name is Galana Uwe. I am Mohawk from Six Nations, and I'm practicing, I didn't know what to call it. So I just say it's like holistic healthcare. And it's actually this, it's a combination of nutrition, holistic healthcare, functional medicine principles, just cultural norms. But my question is around the adverse childhood events. About 100% of my patients have about 4 or 5 adverse childhood events, and actually adverse adult events that are ongoing. And that is a huge part of my practice, is the narrative approach, and actually helping patients to locate those and see the link to their decisions, their choices, and their current state of health and well-being. I haven't heard anybody talk about how are they addressing those things in their practice, and can I come and get a job?
Can I address that?
Yep.
Actually, so I work in Sauble Beach. We have many patients from Saugeen First Nations and the Cape Croker band, which is north of us. And I actually have most of the senior leadership as patients now, so we're making connections. And my wife is also a social worker and an equine assisted therapist. many of the Saugeen patients are now going over to Port Elgin for equine therapy. And so we're addressing those issues. The other thing is I found in one of the, I think it's at the Cape Croker Band, they actually have a lady who visited Vancouver years ago and is CHIP certified. So she eats plant-based and is trying to bring whole food plant-based nutrition to their cultural group that's up there. So we're going to be doing, starting in the fall, we're actually going to be doing some point of care service for those folks. We're actually going to go to their healthcare centers. I'm going to go alone, but I'm going to probably take my wife and whoever else from our center wants to go with me. And they've already told me that they've got really good chefs that can cook the way we ask them to cook. So we're going to do an education session and we're going to eat together. And then there's interest, like I used to do the Walk with the Dog program in London. I may actually start doing the Walk with the Dog program on the reserve. Because again, I think, you know, it's the same problem no matter where you go with Indigenous culture right now. Like my wife, you know, and we're finding this very high level of, you know, you're right, it's average childhood experience, but they're adults, they're in their 50s, 60s, 70s, and they're getting triggered by other life events that have never been dealt with. So it's on our table, and actually we hope to, there's a group from Western that wants to partner up on a research project as well. So we're taking baby steps to get there because we want to do it right, and we want to do it very culturally sensitive. But they're interested, you know, and like I said, I think they, you know, they themselves have been doing a lot of reading and know that there's a better way. They just don't, as you've seen, you've got to cultivate a champion or a half a dozen champions to get the work done. It's hard work, it's heavy lifting. You know, you've got to have an open ear and you've got to spend a lot of hours. Yeah, but it's keen that actually both bands want the same project to happen. So we may actually share resources between the two of them. And once we get going, I'll invite you out. Yeah, we'll try to show you how. But again, where you live, I'm sure you can find a lifestyle medicine champion.
I'm on my own.
Oh, you're on your own?
Yeah, and I'm a family doctor, but I work with, I shouldn't say I'm on my own, I work with traditional medicine practitioners.
Yeah.
So we have like, that's a really good connection.
Yeah.
But I'm trying to get them on board to understand this whole way of working together.
Yeah, it's all, I mean, you hit the nail on the head, it's all linked, right?
Yeah.
It's all linked. Yeah.
Okay, next question.
Thanks very much. I'm a cardiologist from McMaster as well, and I've been through this for 30 years. We were Dean Orange analogs for a while. It didn't stick. Second group of broad patients, it doesn't seem to stick well, so we're failing miserably. And getting patients to be engaged and motivating, I get that. We try to do that. I think of medical school for patients. But most people drop out. I'm too tired, I'm too busy, they have no time. So I feel really stuck, and I need some pearls how to get there. You mentioned people that have issues in childhood and things of that nature. How do we fix that? I'm also from evidence-based medicine, where we have the PURE trial, the cardiologists who feel differently. And if you look at the data, it's tough literature. So how do we figure this out a little bit better?
I'll just take a first crack at this because I'm a family doc. I just got out of the military, and I was practicing this in the military, and one of the problems was I was seeing patients, and I had a couple of people take it up for back pain, but most people didn't. Why? Because they're looking for a quick solution. When I was working walk-in, again, very few people were interested, and so I had a couple of success stories, but not many. Why? Because they were not in the walk-in clinic for that. They were there for their UTI or their prescription refill, and you know, so, but now I've got a practice which is struggling, I'll be honest, but it's exclusively for lifestyle medicine. So everybody knows what they're getting into when they come through that door. And what I would suggest is, sometimes people are interested in prevention, but usually if they're scared enough, unfortunately, or if they're in enough pain and everything else they've tried hasn't worked, then they come in my door, and then usually there's good uptake, or they decide they're not bad enough yet, but at least now they know about it, and there's informed consent, I would argue, for everything else that they're going to be doing. Now they know that this is an option. That's my first track, if anybody else has something to add.
I do have something to add. First of all, can you hear me? First of all, about the PURE trial, because you are aware your colleagues are publishing the PURE trial. So I remember the day that that trial came out, it was August, the first wave of publications related to the PURE trial. And all us lifestyle medicine docs, literally, most of us were on vacation. We spent that night analyzing that thing to, nth degree. I encourage you to read analysis by Dr. David Katz. He is a lifestyle medicine champion, and he has done criticism of the PURE trial and each of its iterations, and I really encourage you to read that if you want some ammunition. The other ammunition you have is getting familiar with the plant-based nutrition literature and way beyond Dean Ornish. We're talking sort of the more recent stuff that is coming out, and that is helpful in challenging your colleagues. But if you want to really sort of talk to these people who've done the PURE trial, I encourage you to read these criticisms by Dr. Katz, which will sort of do an introduction to the criticism of the PURE trial, because it's Canadian, it's important. I don't know if Subas has anything to add, because you're at the same center.
Your voice is trailing away.
Oh, sorry. Okay, I've just...
I'll let Dr. Schmidt go.
I guess to get to your point, I mean, it's difficult to engage some colleagues on this, and I actually, I'm doing things so differently in the community I'm in that I actually had to invite the diabetes educators from Grey Bruce to come to my office and I had to let them know what I was doing, because people were going hypoglycemic and they were encouraging them to eat more carbohydrate, and I was encouraging them to eat more plants and lower their insulin. And so there was a disconnect until we got on the same page. It's the first time I've ever met with diabetes educators. In London, before I left, I actually I spoke to the people at the cardiac rehab program, because the uptake on behavior change after you go through a cardiac rehab program is, you probably know the number, it's 3%. So 3% of people who are forced into a cardiac rehab program don't succeed, because the message is being delivered poorly, and it's being delivered by people where there's no connection. And this is the problem, even in our diabetes education, is you get to meet the diabetes educator twice a year based on, on your diabetes, and you don't get the right message, and it's not delivered in the right way, and they're not as directive in the nutritional pattern that they try to give people. Yeah, I know.
Dr. Jenkins has some comments.
I just want to say a quick word about the PURE trial, because I'm currently involved with the folk at Master. I think it is a good trial. I think that it's not been interpreted, certainly by the media, the way it should have been interpreted. What I think the trial shows is that very high refined carbohydrate diets are not necessarily good things. If you then compare other foods like meat or dairy in very modest amounts with a very high carbohydrate, rather lethal type of diet, then you're obviously going to come out with the conclusion that starch and starchy foods, which are part of plant foods, are not so good as meat. And that's the interpretation, and it was a glib interpretation that I think was taken by the press. I think if you actually read the second paper, the second of that particular series that came out, you will see that peas, beans, lentils, fruit, vegetables, these were protected. So I do think, and we're doing more analyses now on that trial, and I think you'll be pleased with the results. So I would warn you that this study, which is a very extensive one, it's 145,000 people in parts of the world that have not previously been surveyed well, India, Africa, the Middle East, and so on, not just North America. This study, I think, has the capacity to actually endorse what we're thinking about. So please don't dismiss it just yet.
Yes, so the carbohydrate aspect of that study absolutely is supportive of whole foods, plant-based. It's more the fat that got the headlines. The more saturated fat you eat, the fewer strokes you'll have. So if you have even 1 second of comment for that, or maybe we don't. Do we have a second for that? Okay, good.
I would say for that, again, it's always, whenever you deal with these sort of issues, always look at the comparator. When you're looking at saturated fat and you're comparing it with high starch, then even if that's not actually mentioned, that's the comparator. and therefore it doesn't look good. So anything bad looks good against something very bad. It doesn't mean
that's the old Dr. Greger line, compared to what? So we'll finish with that because we've run out of time. Thank you to our panel members. And